your business very much looks at disease management programs particularly, and you're dealing with mental health and substance abuse. And so really you can give us a picture of broader than hospitals per se, the healthcare system as a whole. And I guess this is of increasing importance when we look at the rising burden of chronic disease, the need for long-term care. So I guess from your perspective, what are the things that are happening, the things that you're doing, but also the things you're seeing in the environment in people who are working across the continuum? And where does that evolve to?
Sure. Well, I think it picks up on what was just commented on in the last panel. I've had a career for about 25 years where I've essentially worked for payers. They've been employers, governments, health plans, et cetera. And I'll give you an example. I was the State Secretary of Health and Human Services here in Massachusetts under Governor Romney, and he would always comment to me every year when we would come in with our budget requests and said, Tim, I got elected to do education, to do infrastructure within the state, but every year any new tax dollar that comes into the state, it goes to you and to healthcare. And I don't get to do what I actually came here to do. And that's a fair question. That's a question that gets asked not by governors, that get asked by CEOs of companies, they get asked by anybody who has to deal within healthcare. The cost goes up all the time. And so, to get to your point specifically, the question that we always ask ourselves, well, where are these dollars going? Why does it grow so much, and are we getting value from it? And I think as everyone here kind of understands that, there's a small percentage of the people in this country who consume a large percentage of the healthcare dollars on an annual basis. So kind of 10% drives 66% or so of the cost. What's important about that statistic is there's a sticky 50% of those people who are in that top 10% cohort every year, 2014 and 15 and 16. And as you're referring to, a lot of those individuals have chronic health conditions. What we know in the company that I run, which focuses on mental health and substance use, is that those conditions are amplifiers of uncoordinated care, of unnecessary spending, and of poor health outcomes. So as an example, if you took somebody with a lot of physical chronic conditions, they are clearly people who will be in the top 10% cohort. They're sticky every year. They're spending that money. If I were to break that cohort down and say to you, with or without a behavioral health condition, the person with the behavioral health condition and those physical chronic conditions is going to spend 2 to 3 times as much as someone with a lot of physical complications, but just not a behavioral health condition. So the question you then ask yourself is, well, if that is where the money is, and if that is where we're not getting good health outcomes for those individuals, how do we start to organize around that, if you will? How do we micro-target this situation? And I think where we are right now is in the following kind of pathway from my perspective. One is we're finally at a point where we're getting good information and data to kind of identify who these individuals are and why are they failing within their treatment. Now, identifying people and where they are is just one step. The next step is about engagement. And this is a challenging step. If you kind of identify who you think you should be kind of wrapping around in a more holistic way, engaging those individuals in their healthcare is not an easy thing. Many of these people aren't just medically complex or have a mental health or substance use condition. Many of these individuals are unstable from a social perspective. Instability in housing, instability in jobs, instability in transportation, instability in the family unit. They make these individuals complicated. So kind of what I would argue is what we're doing well on the data part. I think what we're trying to emerge to is how do we get engagement with these individuals? Because if the individual is not engaging with you, you can have all the best services, all the best continuum of care, but the fact of the matter is they're not in their they're not a partner with you, and they will, when they have issues, find a solution in emergency room. They will find a solution in an unnecessary inpatient stay. So I would just argue that's one other element of it, and I'll just conclude here, not to monopolize time. If you're able to engage folks, what's the right approach then from engagement? And the argument that we make, and I would submit, is it is not a person, it is not a series of conditions, it is a person. And you have to think about them in a holistic sense. What are their medical issues? What are their behavioral issues? What are their social issues? And how do I plan through that? And what I would argue, and the arguments I've made when I worked for the governor and the arguments I've made to state policymakers in my current role is, sometimes a lot of those solutions are not going to come in a healthcare claim. It is about other things that we need to do in their life to gain them stability in order for us to go and address that. So I'll pause there because there's a lot to cover, but that's the types of things that I think through in terms of where is there an opportunity kind of from, to create value being defined as better health outcomes, and we're doing it in a cost-effective way.
Thank you. I mean, there's a point I'd like to come back to, and maybe you will all probably have comments on this, is, we talk about patient empowerment. It's the ones it's the people who are going to be really hard to empower that are actually going to be high-end consumers of healthcare, if you like. And so when we talk about patient empowerment, there is going to be this inequality that arises. So it's just something to, how do we address that if we think about the healthcare of the future? I mean, any immediate thoughts? And it's actually something I want to ask all of you, but I'll come back to it. But do you have any immediate thoughts on that point?
Were you looking at me? Or
No, Tim.
Well, I think when we speak about empowerment, I think we have to recognize that a lot of folks are at risk, and so therefore we have to put up structures to allow them to be empowered. And in that regard, that is making sure that you've got the right kind of approach about care management structures. Where they are in their community. You're going to be culturally appropriate with how to engage these individuals, linguistically appropriate. I mean, I can go on and on. There's a lot of kind of factors about getting these individuals engaged with you and how you wrap around them appropriately. It's as I say to my team all the time, this is evolving. Like, we don't have this all figured out. It makes the work that we do very worthwhile, and we're at a fun point in the work that we do because there's a lot more tools available to us today. There's better data to figure this out. We're going to hear about a continuum of care on the mental health side for children, these community-based and home-based services, whereas before it was office-based or go to an inpatient, and how these things are being built out. These are, kind of very dynamic times. So, I'll just pause at that point.
Yeah. So I think that naturally leads to you, Kim, actually, with, and with your the child guidance services. And again, it's the bigger continuum of care and potentially these hard to reach populations that you're dealing with.
Right.
So I mean, where do you see your business and that sort of business going in the future and contributing to health and healthcare?
Yeah, great question. I just want to say thank you for including me today, and I just want to say that I think it's a testament to The Economist to have mental health represented here today, because often mental health is not included in these kinds of conversations about healthcare. It's sidelined, it's considered kind of ancillary, and we learn all too often how important it is to the well-being of many people in our communities. And I think to really make sure that people do feel empowered, people who are marginalized right now from healthcare, is to really know our communities, to have providers who are out in the communities, to have care coordinators and case managers who are getting to know folks. It's really, I think, at the local level, because we can talk high level, big picture, but it's going to be the people on the ground that are really going to learn what the barriers are, learn what immigrants are coming into our town, and what are the stigmas that come with seeking treatment in general for any kind of problem, and also for mental health and substance abuse. Because we just won't know that unless we are really in the communities, working with other community-based organizations, and getting that kind of information, and becoming partners in kind of an informal manner that will make seeking treatment feel safe to those who are not otherwise coming for treatment.
And how does that, I mean, in terms of making that happen, how does the mechanics of that work? Can you give us some specific examples of how that has worked for you, for your organization?
Absolutely. We have coalitions in the areas that we serve in Connecticut. We make sure that we're active members of the Early Childhood Coalition, or the Youth Task Force, for example. We just joined the Youth Task Force after Mental Health First Aid Consortium, and we have teen leaders now who are partners with our staff. They know our staff, and these teen leaders will reach out to us when they or a classmate is concerned about someone who may be suicidal, homicidal, or depressed. Because what we're finding is that our teens are not coming to us to seek treatment. Their friends might be concerned about them, but they themselves are not coming. And so it's through this kind of side door way that we're getting to folks who are not otherwise seeking treatment. So
yeah, and what are some methods of ensuring continuity there? Because I guess, at least if you enter through the front door of a hospital, then your records are put on an EMR. You're in the system.
Right.
Where you have these sort of side entrances and
Yes.
the people making contact through non-traditional, non-conventional routes.
Yes.
How they become patients, but how are people captured in that system and taken through it?
Well, if we have a name, we enter them into our system. If we don't have a name, then we're kind of collecting them as, anonymous someone, and we are documenting all of that information, and then we may be able to connect the dots down the line. But another thing that you just reminded me of is we do go out into the community to provide our services as well. So once someone has identified that they gave us their name and they said, please, we need urgent services, we will go to them. And we have some payers who will support that treatment, and then we have others that we're advocating for to continue to support that.
Right, okay, and that's another, we'll come back to the issue of incentives and reimbursement for this kind of activity. We'll come back to that though, because I want to give you a chance, Helena, to talk about, I guess, we've been talking about going out into the community, and pharmacy has the potential to do that, and it's a touch point for people when they're getting ill, before they get ill, and also when the presence of chronic disease, and as that grows, it's an important outreach mechanism, I guess. So, and I believe that's something that CVS Pharmacy is heavily involved in, is kind of using that retail pharmacy as a touch point to care for patients.
Yeah, I think. Well, first of all, it's great to be here. One of the themes for today has really been about the consumerization of healthcare, and so much of what we see is that we have 5 million people a day walk in our stores, and many times we're the most accessible place from a consumer perspective in navigating a lot of their questions. So, back to, if you think about the people who are the most chronically ill, maybe they're seeing their doctors a couple times a year, but they're in our pharmacies many times a month. And so what we're really working on as a company is thinking about how do we bring all the assets we have together, the great technology with the consumer-facing connections we have to really make a difference. So hopefully many of you saw just a couple weeks ago that CVS Caremark became CVS Health. And that was really celebrating the fact that we took the big decision to get rid of tobacco in all of our 7,700 stores. Thanks. That's great. As you can imagine, that was a hard decision. It's $2 billion a year in sales, and so we debated that for several years, and we made the decision that we could do this year, and it was sort of one of those things where when we announced it in February, we just said, wow, we know what's really happening in our business is we're becoming more and more of a healthcare company. And as we're going in and talking to hospital systems and doctors groups and health plans and other people in the healthcare community, we would tell them all about all the great things we were doing, and then inevitably someone would raise his or her hand and say, all that sounds great, but why do you still sell cigarettes? And so we said, you're right. And the only reason we were doing it was really hard to walk away from all those sales. And so we made the decision. And I think what's been really exciting just in the last couple of weeks is the unleashed energy that this has really created, both among people who use our stores. The response has been unbelievable. People feeling very much like you are a healthcare company if you're willing to do that, but also the pride among all of our employees. So we have 200,000 plus employees that work across the company, and they feel very, very proud that the company would make a decision like this. But what it really represents for us is the marriage, as I said before, of all the things that we can do to really help patients. So CVS Health represents really 4 business units. One is CVS Pharmacy, that everyone knows, 7,700 stores across the country. CVS Caremark is the second leading pharmacy benefits management company in the country. We also have CVS Minute Clinic, and we have the largest suite of clinics, retail clinics in the country with 900 of those. And CVS Specialty, which is a very large provider of specialty medications. So what we've been working on in the last 6 or 7 years as we've all come together is how do we take the power, for example, of a PBM which has a lot of data and technology, but who in the world typically knows who their PBM is, right? No one. But what people do know is their pharmacist. So we've developed, for example, a program we call Pharmacy Advisor that allows us to really serve chronic patients in a different way. So an example would be people with diabetes. We know as a PBM, these people who are on medications, and we can see when they stop taking them. So what we have set up is through a lot of sophisticated technology is a system where when those patients are at our pharmacy counters, even if they're just picking up an antibiotic, if we know they've stopped taking their insulin, or maybe they have a gap in their care, they're not on an ACE or an ARB, we actually ask them if they'd be willing to have a 2-minute conversation with a pharmacist. And our ability to get them back on therapy is very, very high, including depression, which is a disease state that we just started about a year ago, because we know that many patients with depression have left their doctor's offices with all the best intentions, but don't quite understand all the side effects. So a pharmacist really can be an important partner for the patient. So the value of all of this is we can keep people on the right medicines and really help them get to a place where they're healthy, they're staying out of the hospital. And the value to the system is better health outcomes at a lower cost. So all of that is coming together with what we've been trying to build from CVS Health perspective. And ultimately, it's about taking advantage of the personal relationships we have with the patients we serve every single day.
And how does that work in terms of the relationship with payers and in terms of reimbursement for those sorts of activities?
Right. So I mentioned CVS Caremark is one of our business units. It's the largest pharmacy benefits management company, second largest. And what we do is we serve big employers and health plans and government agencies to basically manage the prescription side of their benefit. So we are, on the one hand, negotiating with pharmaceutical companies to keep the costs down. We're negotiating with all the pharmacies, including CVS, in the network to keep the prices down. And so a big part of how we win business is going in and not just competing on price, because there's only so much you can do there. It's really convincing the clients we're serving that we're producing better health outcomes because of the suite of the assets we have. So CVS and CVS Caremark have been together for about 7 years now. I'd say when we first came together, people hated the merger. They thought it was a disaster. They thought it couldn't work. And now we are really winning in the marketplace this year. We won actually over $5 billion in net new PBM sales, and that's in many ways because people see the different outcomes we can create because we've got the integrated business model.
So I'm going to ask you now, Sandra. I mean, Boston Children's Hospital obviously has a worldwide reputation and one of the top children's hospitals in the world. So in terms of, and that's come from a traditional hospital background in the past, how is it evolving? What makes a hospital like yours successful, and what will continue to make it successful in the future as all these developments take hold and as we see these changes in the way people access and use health services?
So first of all, I'd like to also thank the Economist for including children. Mental health is obviously a critical component of what we're all dealing with, but children are clearly our future, and because they don't vote, because they are a small component of the healthcare dollar, they're usually not even in the conversation. So thank you. Well, for Boston Children's, I think everything has always been about two things. One is around our people and the commitment and the devotion to really delivering on the promise of taking care of children, whether they're in the community, whether they're in the sickest component of our delivery system. But it's also about innovation. And although the other panel was talking about innovation, I think that's really what has put us on the map, what continues to ensure that patients come to us because we are always, always saying good is not good enough. If we don't have an answer, we need to find an answer. If we are using technology, how do we use technology to advance the care of kids? How do we merge both the care side and the research side and innovation to really drive this whole value equation? For us, and I think one of the ways we tried to articulate our own value equation is that it's not a simple quality over cost. It's truly delivering on quality every time, every patient, and really starting to push the boundaries of being able to articulate what that really means, and trying to be leaders in articulating what quality and safety and outcomes means in children. And not only to be satisfied that we're doing better against ourselves, but also how are we doing relative to others who are our peer institutions. The second part of that is, are we really, truly interfacing and understanding what the consumer needs, and how the consumer is changing in their own expectations for access, for information, for engagement and involvement in the care of, in our case, in the care of their own children, and how do we ensure that they are not only getting the care that they expect for their children, but the whole process and the whole system of delivering that care, whether it's in their home, when they come into the institution, and when they go back again. And the third piece is innovation. Are we basically saying that if you don't understand, or if wherever you are, you don't understand what's going on with your child, or there's not an opportunity for a clear diagnosis, there is an opportunity for us, because we're constantly pushing, whether it's the research, the discovery, the translation of that research to the bedside for better diagnostic capability and clearly better treatment. But that all has to be also clearly divided by cost, because there is no question that doing all of this at any price is not sustainable. It's not sustainable for us as a business model, and it's clearly not sustainable. We have 10,000 employees. We have the same sets of concerns and issues as everyone as an employer in paying for healthcare. But we also have a responsibility to our state, our governor, our legislature, for delivering care to the population we serve, to employers. And so it is extremely important that we're actually getting at not only the unit cost of care, how do we take cost out where it doesn't belong, but how do we make sure that the care that we're delivering is effective, and it is in the right setting, it is the right utilization, it is appropriate for what's needed. And so we've been working on all those four elements to ensure that patients who come to us not only come to us as a destination for some of the toughest challenges that they face, but even for the most routine care, they're getting what they expect, what their expectations are around service, around access, around quality, and around cost.
So I'm going to ask the same question that I asked earlier to Tim, is around the harder to reach populations, the people who you know, the thing we talk about, the inverse care law. How do we, which is the people who need the care the most are often the ones who find it difficult to access it. And if we're talking about patient empowerment and engagement, that's going to be a critical segment of society we need to reach. How is Boston Children's reaching out to those sorts of?
So we serve a local community, we serve a regional, a national, and an international community. And increasingly, all of those components are growing. And so we have to think about, how do you reach all of them? There are cultural, as Tim said, there are so many different components to this. There are cultural, there are language, there are social, there are educational issues that we all have to figure out how to break through. And it isn't how do you get them to come to you, but how do you also go to them? How are we increasingly using not only technology to reach out globally? So we've created on a global basis something called Open Pediatrics, where we are increasingly trying to extend the knowledge so that patients don't have to come to us, referring physicians don't have to come to us to be trained, but we can actually reach out through a cloud-based learning platform that we developed with IBM to increasingly educate and train people out in the rest of the world to extend care so that they don't all have to actually try and come directly to a place like Children's. So that's on a global basis. On a local basis, and you can think about all the steps in between, it's very important for us to really understand how to reach patients in their homes, how to reach them in the primary care setting or in the community health centers where they access care. And just to give you an example, asthma is a huge issue among the inner city. And one of the things that we've done is to actually figure out how to go into homes and not just train parents and teach parents how to give asthma meds, but the whole environment where these children live is exacerbating their medical conditions and sending them to the emergency rooms and the inpatient units. And so we've gone out with care providers that actually start putting in HEPA filters and vacuum cleaners into the homes. We've actually changed mattresses in the homes, eradicated rodents and insects in the home. And based on this program that we've had in place now for about 6 years, we've been able to reduce the emergency unit visits of these 1,200 kids by 65% and inpatient admissions by 85%. So it's not just educating the parents to come to the doctors and get their meds and take their meds, but it's how do you actually look at the whole environment that these children are in and help them. Mental health is probably the largest growing challenge we have as an institution. And so we are trying to now think about how do you embed mental health workers in the medical home or in the primary care setting, because the stigma many times, it's not just can you engage them, but how do you get them over the hurdle of basically accepting that there is a need for care. And rather than say, now we're going to write you an order to go see a psychiatrist or a mental health worker, how do you actually say the person sitting in the next office is going to actually help you think through this whole thing? And how do we prevent that need to even go the next step and the next step or into crisis? So those are the kinds of things we've been working on, because part of this is not just how do you treat everything that ends up in our emergency room, our clinics, or in our hospital, but how do you actually prevent some of the things that really are manageable and preventable before they even get to us.
So a question to any of you, really, I guess, is, you've talked about, some of the things you've all touched on is stuff dealing with and intervening in ways that are outside the normal or the conventional biomedical model. So you're talking about rat catching, or and you're talking about interventions that will help in terms of psychological disorders and things like that are outside. So a narrow question is, how does the reimbursement mechanism for that work? The broader question is, what are the things that have to happen outside the provider environment to facilitate what is clearly a good thing? So yeah, any
I'll
comments?
start. So what I think is exciting about this industry right now is a lot is changing, and I think as we're changing, we're really all rethinking. I mean, Sandy, your story about how you're thinking about your patients with asthma is a great example. And so what we're really working on is how do we get ourselves much more integrated into the rest of the healthcare system so we can produce better results. And so, for example, I mentioned MinuteClinic. We have now 40 partnerships with hospitals all over the country where we've started by connecting our electronic medical records so that when we're seeing a patient from the hospital, we can see all of their information right at MinuteClinic and vice versa. But that's then leading to a separate set of opportunities, which is as doctors are starting to get paid on the outcomes of their patients, a very natural way for them to think about an opportunity would be, gee, I've prescribed all these medications. Are my patients, in fact, staying on them? And in an old world where you might have thought about the pharmacy as just a commodity, you can get that medicine anywhere you go. In the future, we think that doctors and hospitals will start to look for pharmacy partners who create better outcomes because they're better able to keep their patients adherent to their medications. So that's something we're working very hard on. We're proud of the fact that our medication possession rates, for example, are very high because of the kinds of programs we've developed. But we think ultimately where that will really come to play will be different reimbursement models. And as you think about the next 10 years, it's hard to imagine we won't live in a world where doctors aren't really reimbursed based on the total outcomes of their patients, including all the mental health issues, but not just on a fee for service. And then that starts to really create a very different dynamic for all of us in this industry.
I think the challenge that you have with regards to kind of what you would consider kind of non-medical or traditional services that could amplify someone's opportunity for success is that you have some major payers in this country, Medicare, Medicaid, and then you can put the Blues and the big health insurance companies. And there's a couple of facts about that. One is their SOP is we pay for codes. We don't pay for these other types of things. And why don't they do that? Well, one is their information systems do that. Like, how do I pay for these services if I can't transact them? That's a challenge. Second part is they get concerned about fraud or things that are ineffectual. So when I was secretary, we had a program for children that were at needs, and I remember one particular example where my commissioner of the Department of Mental Health came in and said, what we really need to do is to buy this young woman a prom dress. Because this is what, if you think about from a person-centered planning perspective, what she had kind of laid out for achieving stability in her life was to go and attend that prom. Family couldn't afford it. How do you pay for that? Who's making that decision? And think about headline risks on those type of things. Government pays for a prom dress. Okay, well, but I avoided 3, ER visits as a result of that. So I paid $120 versus $3,000. That's probably a good deal. However, how do I then ensure that that doesn't go haywire, that it's not, not well kind of documented? So, our payers of the system are necessarily small c conservative. They don't want to move too quickly because they're afraid of unintended consequences or dollars being kind of stripped out. So the good news is that we are at a point, though, where people are, kind of recognizing we need to do something different. Fee for service doesn't work. Paying for what we've been paying for the stubborn kind of, if you will, persistent folks who continue to not do better and spend an awful lot of money, we've got to think about this a little bit differently. So we are kind of at this era right now, well, maybe we should do subcapitation arrangements, and I'll pay you this. You deliver good outcomes. Whatever you put inside that mousetrap, I'm probably going to allow you a little bit more latitude. And you're seeing CMS under this current administration try to be flexible on this particular point. I'll give you an example just with locally here. Blue Cross Blue Shield in Massachusetts and Beacon Health Strategies on April 1st just went out with a more, kind of a model type of program for people who are at risk for serious mental illness, in which the traditional Blue Cross Blue Shield benefit for a commercial member doesn't cut it. It doesn't have the flexible community supports built into it. Blue Cross, though, recognized in the era of the Affordable Care Act, in which young people can stay on their parents' health plan to the age of 26, they looked at their data and said, wow, we have a lot of first break psychoses that used to be candidly off our plan pretty quickly because our benefit was narrow, or the child got to 18, 19, 20 and therefore was no longer eligible for the parents' health insurance, so they went to Medicaid or uninsured. But under ACA, you can stay on your parents' health plan until you're 26. Big spike in spending. And what they've recognized is that our approach of a capital B benefit doesn't work for them. So Beacon, can you come in? Or we said, well, we're happy to come in. And we can create for you a flexible package of supports. You can pay us on a capitated basis. We're going to pay for things that you normally wouldn't. Not everybody at Blue Cross, the 2.5 to 8 million people at Blue Cross are eligible for this. You have to qualify in, if you will. But we're going to be more flexible in those supports. And we're using things that, that we've done in Medicaid for years for now a commercial population. So those are kind of a couple of examples where I think you're starting to see cracks in how you get flexibility, but recognize that, there's a journey here because payers are conservative. They get nervous about things that are new. They get nervous about how they transact it, how they track it, how they account for it, and they don't want to be subject to things that, the classic woodworking effect. It just, because you offered something, it went to a whole bunch of people who didn't need it. But I think that we're, I note that we're in a much better place than where we were even 5 years ago on these types of conversations.
Move to the floor now. We've heard some interesting, exciting innovations from all of our panelists. Any questions for them? Any comments? come on, there must be some. No?
End of the day.
No? Okay, well, I'll yeah.
Can I pick up
Yeah.
on a little bit what Tim and Helena said? One of the things that I think they both talked about were partnerships and how important partnerships are going to be in really trying to solve this. And I think this came up in the last in the last group, where we cannot solve these things alone. We need data, we need evidence, and we need partnerships. And so one of the things that we did was to put together all the major payers. It was the first time they had ever sat together, the medical directors of the 3 major private payers, and we brought the chief medical officer of Medicaid together. And when we were in the process of trying to reduce some of our costs, we said instead of giving it back directly to the payers, would they fund a fund to actually have us experiment on some of these kinds of initiatives. And so we put them together as a little board with some of our own clinicians. And we then basically put a granting opportunity out there for people to come forward with different ways to try and look at improving the quality, reducing utilization, and reducing cost. And they came up with a whole series of different projects with the payers at the table who said, okay, we will grant, a certain amount of this money to these projects. We want them to, as part of that, show the evidence that they are actually improving quality, reducing utilization, and reducing cost. And on the basis of that, they not only were intrigued by what came out of that, but it started to have them experiment with actual different payment models for paying for some of these services. So for instance, one of them was we take care of a large number of kids who are on chronic ventilators. Either they have chronic disease where they have to be intubated, and many of them end up going home. And their parents and their caregivers are actually managing them in their home. Most of those kids, when they get sick, end up coming directly to the intensive care unit. They don't even go to the emergency unit. They are so sick, they go straight. And so one of our group of doctors said if an intensivist and a nurse practitioner or respiratory therapist could be on call and go to the home when the parent thinks that the kid is starting to deteriorate, maybe we could actually either start an antibiotic or we could change a ventilator setting and avoid not only a trip to the hospital, but an actual stay in the ICU. This was one of the projects, and we were able to show an incredible reduction. I don't remember all the numbers, reduction in the number of these transfers and stays in the ICU, and you can only imagine what the cost of an ICU day is for each one of these. The payers then said, this is incredible. Let us now try and figure out how to package this, because the only way we could do this, since there was no code, there is no home visit code, there's no code for an intensivist going into the home. How do we do this? And I think it was based on the evidence that we worked on together that has actually gotten them to think very differently about how to even pilot some of these things. So I think that it's all about all of those things coming together.
I'm so happy to hear about that, because in Connecticut we're really struggling with getting that flexibility, rolling out that flexibility for these creative treatment methods. And we have a few evidence-based treatment models that we use in mental health that require a lot of upfront investment in staff training and supervision that really have promising outcomes, but it's a struggle when the reimbursement doesn't really recognize all of those treatments, and we have to rely on private donors or grants to really make up the difference. And so that leaves us in a little bit of a tenuous financial situation.
So that kind of brings to mind another thought, which is that I guess many of these innovations may be happening in smaller and medium-sized enterprises, maybe don't have the negotiating power or the ability to get the ear of the payer and say, let's try something out. I mean, how critical an issue is that, and how do people like you navigate that in the future, and how can people like you help?
I'd love to bend your ear. We basically work together with other similar organizations of our size or larger, that are working in the mental health arena and trying to negotiate with the payer. You know, many clinics in Connecticut are Medicaid providers, and we meet regularly to try and advocate for what we think would be an appropriate continuum of care and what kind of reimbursement would work for us, and not put the services in jeopardy, because that's what we often find to be the concern. If anything shifts too much, what happens to our safety net? And so we kind of have to balance two things. Let's reward innovation and positive health outcomes, but also make sure we're not kind of ripping the rug out from underneath the safety net.
I would just add too, I think looking more broadly across the country to say, where are there pockets of innovation happening? So one of the things we're in a fortunate position to have is 2,000 clients who are essentially payers. And we can look at those who we think are really innovative and start to learn in partnership with them. So a good example for us is Care First, is the Blues of Maryland and Washington, D.C. And they have a very progressive program as it relates to patient-centered medical homes and really setting up reward systems for the primary care physicians to have skin in the game and opportunity to really save costs and produce better outcomes. And so we've been able to work really creatively with Care First, for example, on who are their 1% of most chronic patients. What could we do differently in a CVS pharmacy and with all the other assets we have in Minute Clinic? And so I think we start to get inspired by some of the pockets of innovation that are happening in some cases more geographically, because you've really just got a very innovative insurer. That's also true in Hawaii, for example. HMSA is the big Blues of Hawaii. We are also their PBM, and we've got, you know, a lot of pharmacies and Minute Clinics on the islands. And so again, we can go to those places and start to explore. And then once you get great outcomes, you could start to, I think, convince the other systems that there might be a model here.
I think that's an important point. I just would note, you know, it's funny, we're right now just about to merge with our kind of largest competitor, and the reason we're doing it is that we recognize that scale matters a lot. In order for us to diffuse kind of great, you know, models locally, our idea is to say best practices here in Massachusetts. I've got to manage behavioral health care in Southern California. How can I make that applicable? Different, you know, kind of roles that county governments play out there versus how they do here in Massachusetts. But there are best practices that occur. And, you know, I think to the point that Helena is making, it's that, you know, scale does really matter. And I would just make the point here that I think it fundamentally has to transform how payers think about what their job is, because payers are the only ones who actually sit there and own all of the repository of data, whether it's pharmacy or it's inpatient at a children's hospital, or whether they're reimbursing an FQHC visit, right? They have it all. But for years, and I say this as someone who represents a managed care company, but I'll put my old state hat on, most insurance companies view themselves as volume discounters and sales and marketing organizations. They don't view themselves as health integrators. Mm-hmm. And that's where they need to go. And to do that well, you do need scale. And we're still in the early phases of how these mergers work and how big CVS can become. And in my little small slice of mental health, will, you know, as a result of this merger, have 45 million people under our management. You know, it's not a small amount of folks who will be in all 50 states, but it matters. And that's why we feel like you have to do these things, because I think it's being required of us to be, you know, we just can't be about volume discounts and negotiating power against Sandra and her organization. We need to be integrating care for people and, if you will, proverbially pulling the camera lens back so we can take a landscape of what's going on in a person's life as opposed to, you know, kind of little portrait pictures at one particular time.